For time now, we present Dr. Marianne next lecture and postpone the questions after Dr. Marianne lectures. Dr. Marianne, she will talk about the most risky thing in our department of anesthesia, up to date on the management of obstructive sleep apnea. Marianne Magdy Youssef, lecturer of anesthesia, anesthesiology and intensive care unit, Cairo University. Please, Dr. Marianne, you can join us now.
Dealing with adult patient with obstructive sleep apnea, either in anesthesia or with COVID-19 infection. Hope you find this lecture useful. Obstructive sleep apnea is increasing in prevalence, and the number of perioperative patients with obstructive sleep apnea is likely to continue to rise in parallel with the increase in obesity. Over one half of the patients with obstructive sleep apnea who present for surgery are undiagnosed. OSA increases the risk of preoperative complication and should be suspected or recognized and managed in perioperative period to minimize postoperative morbidity and mortality. The global prevalence of OSA in the general adult population is increasing. For example, the general adult population is increasing, is exceeding 70% patient undergoing bariatric surgery. Risk factors for OSA is classified into non-modifiable and modifiable risk factors. Non-modifiable risk factors include male gender, postmenopausal status, family history of obstetric sleep apnea, and advancing age. The primary modifiable risk factor is increasing in body weight, which is almost twice as likely in patients with obesity, body mass index over 30 kilogram per meter square, compared with non-obese adults. A large longitudinal study determined that 10% increase in body weight translated to 6-fold increase in the odds of developing at least moderate to severe OSA, and that weight loss can attenuate OSA severity. It's important to note that up to 25% of the patients are not obese, with BMI less than 25 kg per meter. Anatomical features of craniofacial structure like retrogenesis and certain aesthetic appearance like Asian are important to recognize. What about the pathophysiology of OSA? It involves cyclic collapse of pharyngeal airway and resultant airflow limitation during sleep, either partially producing hypopnea or completely resulting in apnea. The pathophysiological consequences include hypoxemia, hypercapnia, activation of sympathetic nervous system, cortical arousal, and fragmented sleep architecture, with a subsequent daytime functional impairment. Presence of OSA is an independent risk factor for systemic hypertension, atrial fibrillation, pulmonary hypertension, insulin resistance, and exacerbation of inflammation. How to diagnose the OSA? Diagnosis of the obstructive sleep apnea is through the polysomnography, as Dr. Khaled discussed with you in the children suffered OSA, either at the laboratory or ambulatory. Its presence is established through the apnea-hypopnea index, the sum of apneas and hypopneas recorded per hour of sleep, with a score of 5 or more events per hour being confirmatory in adult patients. An apnea-hypopnea index of 30 or more events per hour is indicative of severe obstructive sleep apnea. In addition to hypoventilation and hypercapnia, can be assessed through transcutaneous carbon dioxide monitoring and arterial blood gas sampling at the beginning and at the end of the polysomnography. Given that most people of obstructive sleep apnea remained undiagnosed, many patients presenting to elective surgery are similarly undiagnosed. The increasing perioperative morbidity highlights the importance of preoperative screening for obstructive sleep apnea. The major international society guidelines on preoperative OSA assessment and management developed by the American Society of Anesthesiologists and Society of Anesthesia and Sleep Medicine support OSA screening as a part of standard pre-anesthetic evaluation. The optimal preoperative OSA screening and confirmation test remain unclear. The OSA screening questionnaire commonly used, including the Stop Bang questionnaire, Epworth Sleepiness Scale, and Berlin questionnaire. Here we use the Stop Bang questionnaire. It's routinely employed for preoperative screening of obstructive sleep apnea with a score of 3 or greater, raising concern for obstructive sleep apnea. While intraoperative polysonography is the most comprehensive confirmatory test for OSA, ambulatory sleep studies and nocturnal oximetry are alternative due to the practical consideration in the preoperative period. Surrogate markers such as polycythemia, hypercapnia, or elevated serum bicarb and associated comorbid features such as hypertension, atrial fibrillation may be present. Although they are non-specific for OSA, the current evidence is not sufficient to support delaying or canceling surgery for confirmatory OSA testing. Perhaps one of the greatest advantages in preoperative OSA screening is identification of at-risk patients to guide risk stratification and modification in perioperative care. Management of OSA as a disease usually depend on the severity, symptomatology, and patient comorbidities, but commonly compromise an oral applicants like mandibular advanced splint, upper airway surgery, or continuous positive airway pressure, in addition to the conservative measures such as weight loss and positional modification whenever appropriate. In addition to OSA, there are several other related conditions that warrant consideration during the perioperative period due to the increased risk and complication. Upper airway resistance syndrome and obesity hypoventilation syndrome. Upper airway resistant syndrome can be defined as being at the milder end of OSA spectrum and typically occurs in younger non-obese individuals who snore and have fragmented sleep with an apnea-hypopnea index under 5 events per hour. This syndrome can transition to overt hypopnea and apnea after surgery and may account for 26% of the patient without preoperative sleep apnea who develop at least moderate grade of obstructive sleep apnea between the first and third postoperative night. Obesity hypoventilation syndrome is demonstration of daytime hypercapnia, arterial partial pressure of carbon dioxide more than 45 millimeter mercury in a person with obesity, BMI more than 30 kg per meter square. While obesity hypoventilation syndrome is estimated to be present in up to 0.3% of the general population, prevalence is as high as 8% among the patients presenting for bariatric surgery. Estimated that 90% of the patients with obesity hypoventilation syndrome have concurrent obstructive sleep apnea. In comparison with patients with isolated obstructive sleep apnea, the patient with hypercapnia from the obesity hypoventilation syndrome are more likely to experience postoperative complication, including respiratory failure, cardiac failure, and unplanned transfer to intensive care unit. OHS should be suspected in a patient with obesity presenting for surgery with resting hypoxemia, restrictive ventilatory defect on spirometer, or elevated serum bicarbonate more than 27 milliequilibrium per liter. The American Society of Anesthesiologists and the American Academy of Sleep Medicine, Society of Anesthesia and Sleep Medicine, and others have developed clinical practice guidelines and protocols for perioperative management of the patient with OSA, with the goal of reducing perioperative complication. These recommendations are generally based on limited evidence and clinical rationale and expert opinion, and include maintaining high index of suspicion for obstructive sleep apnea, careful use of medication, vigilant monitoring for upper airway obstruction, and an integrated team approach for preoperative management. And I think this Dr. Khalid goes through very detail. A choice of anesthetic technique in general is determined by surgical procedures and patient factors like predicted difficulty with airway management and comorbidities, and preference of the patient, anesthesiologist, and the surgeon. But generally, we have to minimize respiratory depressant likely to have residual effect during the postoperative period. For the patient with OSA, a goal for any type of anesthesia, from monitored anesthesia care with sedation to general anesthesia or even regional anesthesia, is to avoid worsened intra and postoperative airway obstruction by minimizing the use of respiratory depressant with effects that will continue into the postoperative period. Most anesthetic techniques can be modified to conform to this goal. Of course, we prefer regional anesthesia forever because regional anesthesia, either the peripheral nerve blocks or the neuroaxial blocks technique, is preferred over the regional anesthesia for peripheral procedure whenever possible. However, if moderate or deep sedation would be required for the patient to tolerate the procedure under regional anesthesia, general anesthesia in this condition will be favored with a secure airway for this patient. Regional anesthesia technique should be used as a part of multimodal opioid-sparing postoperative analgesia. The literature on the benefits of specific anesthesia technique for patient with those patients with OSA is limited. In patients without OSA, the neuroaxial anesthesia may reduce the risk of postoperative pulmonary complication. Those strategies that may use to minimize airway problem during and after sedation have a goal to reduce postoperative respiratory adverse events and consistent with the guidelines. The strategies that may use include uses of infusions at lowest effective doses rather than bolus dosing of sedatives or opioid to decrease episodic respiratory depression. Use short-acting sedatives, opioid like propofol, remifentanil to minimize the carryover into the post-operative period. Use sedatives that are least likely to induce respiratory depression like dexmedetomidine, ketamine. Position head up if surgically acceptable. Use airway positioning to relieve obstruction, such as a sniffing position, lower cervical flexion, upper cervical extension, or jaw thrust. Consider the use of an oral and nasopharyngeal airway depending on the depth of the sedation and the patient tolerance. Consider using positive airway pressure and oral applicants, hypoglossal nerve stimulation therapy, or high nasal flow oxygen during sedation. Administrate oxygen therapy and put in mind that this administration of supplemental oxygen delay detection of respiratory depression, especially in absence of any type of ventilation monitoring. The uses and effects of sedative and analgesia on upper way patency and respiratory reflexes in this patient. Benzodiazepines. We avoid benzodiazepines or use reduced doses of benzodiazepines for patients with obstructive sleep apnea. Benzodiazepines increase supraglottic upper airway resistance, decrease arousal response to hypoxia, and may induce central apnea. Propofol. Propofol is a very attractive option for anesthesia and for sedation with OSA because it has rapid onset, rapid offset, lack of residual effect, titratability. However, propofol causes dose-dependent relaxation of genioglossus muscle and inhibit upper airway reflexes, both of which can cause airway collapse. Thus, Lowest effective dose of propofol should be used by bolus or infusion for sedation, titrate to effector. Alpha-2 agonists, like the clonidine and dexmedetomidine, the trendy drug, have hypnotic, sedative, analgesic effect and may reduce requirement for other sedatives and opioid, with minimal or no respiratory depression at doses used for sedation. Ketamine. Ketamine is an methyl D-aspartate respiratory receptor antagonist with sedative, analgesic, and respiratory stimulant properties. Respiratory stimulant properties, unlike the other sedative. The ketamine does not relax the upper airway dilator muscle, so theoretically can avoid upper airway collapse if administered without other sedative or opioid. Opioids should be administered very, very cautiously and in reduced dose with patients with obstructive sleep apnea. Perioperative opioid decrease respiratory drive, suppress the arousal threshold, and may cause central apnea in susceptible OSA patients. The GABA benzodiazepines, like the gabapentine and pregabalin, are increasingly administered preoperatively as a part of multimodal opioid-sparing analgesic regimen. This medication should be avoided or used cautiously at the lowered dose in the patient susceptible or known to have OSA, since in non-OSA patients, those drugs, when combined with opioid, have been associated with sedation and respiratory depression. Regional anesthesia technique, as we discussed, should be used rather than general anesthesia whenever possible for the patient with OSA. Postoperative outcome may be improved when regional anesthesia is utilized as opposed to general anesthesia. The concerns regarding general anesthesia in patients with obstructive sleep apnea include increased incidence of difficult airways and potential for postoperative respiratory compromise as a result of residual effect of anesthetic agent. Obstructive sleep apnea itself and a number of associated patient characteristics like obesity, large neck circumference, snoring, are risk factors for difficulty with airway management for anesthesia and for airway complication after extubation. Other considerations relate to the comorbidities that may be associated with OSA. There should be high index of suspicion for the pulmonary hypertension in a patient with chronic untreated severe OSA or obesity hypoventilation syndrome. The patient with pulmonary hypertension should generally be managed with controlled ventilation rather than allowing spontaneous respiration, as hypercarbia, hypoxia, and acidosis are triggers for increased pulmonary artery pressure. The concern in general anesthesia, number one, positioning. Patients should be head-up position for induction and airway management, and this improves post-lung volumes, the functional residual capacity, and our laryngoscopic view, especially in obese patient. Obese patient may require additional equipment to provide ramped position, where the external auditory meatus and sternal notch are horizontally aligned like the dark line, the black line in the figure. Second concern is pre-oxygenation and apneic oxygenation. Pre-oxygenation should be performed for all patients before induction of anesthesia. In addition to apneic oxygenation can prolong the safe apnea time for obese OSA patient, any patient who expected to desaturate rapidly during apnea, and for patients with predicted difficulty with airway management. A choice of anesthetic technique. We prefer to use the short-acting anesthetic agent that facilitate rapid emerge from the anesthesia and minimal residual sedation. Of course, we said propofol is a very attractive choice. Desflurane and ribifentanil is also very good choice. The literature on the effects of the various anesthetic agent for the patient is limited and insufficient to recommend the choice of a specific agent. Intravenous and inhalational anesthetic sedatives, opioid, neuromuscular blocking agent can all affect the respiratory muscles, especially the upper airway muscle, and effect may continue into postoperative period. The OSA patients are thought to be particularly susceptible to respiratory depressant effect of those medications because of their blunted physiological response to hypercapnia and hypoxia. Intravenous fluid management. Those patients with OSA may benefit from the restrictive or goal-directed strategy for intraoperative fluid therapy and from fluids with relatively lower salt content, like the Ringer's lactate rather than the normal saline. This strategy is based upon the biological rationale that salt and or fluid retention from administration of intravenous fluid and the stress response of the surgery while the patient in supine position can predispose to fluid accumulation in the neck and consequently contribute to airway narrowing. When feasible, we prefer that those patients are positioned head up to improve this phenomenon. Emerge and extubation. Patients with OSA and difficult airways generally should be extubated at the end of anesthesia when fully awake. OSA and obesity are among the factors that increase the risk of extubation failure after anesthesia. Patients who are fully conscious and responding to your commands, have no residual neuromuscular block, have airway patency, are confirmed at least likely to require airway assistance after extubation. Neuromuscular block should be specifically assessed at the conclusion of the surgery and reversal agent appropriately administered. The risk of residual neuromuscular block during the early postoperative period are amplified in the patient of OSA, especially on those who are obese. These include hypoxemia, airway obstruction, longer post-anesthesia carry-on stays, delay in tracheal extubation, and increased risk of postoperative pulmonary complication. There is limited evidence that the neuromuscular block reversal with Sigma-Dex may associated with less postoperative complication than the newstigmine. The OSA patient should be extubated in head-up position and remain in non-supine position, semi-upright, lateral, during the early recovery period if possible. This table discusses the intraoperative risk and how to take your precautions. But I'm thinking about passing this table for the time. We will go through the postoperative directly. What about the postoperative adjuvant strategies for those patients? Role of supplement oxygen therapy. I think oxygen here in those patients are double-edged sword. Continuous supplemental oxygen is recommended and as an adjuvant of effective CPAP to manage early postoperative hypoxemia when saturation is less than 92%, resulting in improvement on oxygenation and reduction in apnea-hypopnea index. Supplement oxygen therapy should be continued until the patient baseline preoperative oxygen saturation are achieved while breathing room air. It is important to note that the supplement oxygen does not replace the role of patient regular positive airway pressure therapy. Supplemental oxygen can confer risk by masking the hypoventilation and apnea, leading to hypercapnia. This risk increase in the setting of concurrent OSA and the obesity hypoventilation syndrome. Supplement oxygen should be administered cautiously with reduced saturation targets and very attention to avoid hyperoxia and therapy, avoid hypoventilation and worsening of hypercapnia. As I said, it's double-edged weapon. Acute postoperative systemic opioid therapy is associated with increased incidence of ventilatory depression, especially in the patient with OSA. This risk is particularly prominent within the first 12 to 24 hours after surgery. A multimodal analgesia approach utilizing different classes and administration routes should be employed with focus of opioid-sparing strategies. Those include the use of regional anesthesia technique and systemic non-opioid analgesia, incorporating with non-steroidal anti-inflammatory drugs, COX-2 inhibitors, paracetamol, gabapentin, pregabalin. If stronger analgesia is required, consideration should be given to the buprenorphine, which is a less potent mu receptor agonist, or atypical opioid tramadol. which are weaker mu agonist than standard opioid and have less respiratory depressive effect. Of course, when opioid analgesia is administered, continuous vigilant monitoring for the patient and continuous pulse oximetry monitoring is very recommended. Patient position. Related to supine position occur in 20 to 60% of the general population, where apnea-hypopnea index at least twice is great in supine compared to lateral position. During post-operative period, apnea-hypopnea index is significantly higher during supine compared to non-supine sleep. So we should ask the patient preoperatively about the best position he sleeps in every day and try to awaken him in the same position. Now, this is a risk stratification and management of the patient in the post-anesthesia care unit with confirmed or suspected obstructive sleep apnea. This algorithm is very important to summarize how to deal with this patient. If you have a suspected obstructive sleep apnea, you have just a stop bang questionnaire more than or equal 3. This patient should have a prolonged stay in the PACU more than 60 minutes due to any of the following. If any of the following happened and you have a suspected OSA patient, he will stay more in the PACU. Evidence of upper airway with or without ventilatory compromise, loud snoring, apnea episodes more than 10 seconds, bradypnea less than 8 breaths per minute, hypoxia saturation less than 90%, hypercapnia, PaCO2 more than 50, or pain sedation mismatch means significant requirement for opioid with or without increase in sedation level. This patient will go to intensive monitoring if he has those problems. So we will need a monitored bed setting, continuous saturation monitoring through pulse oximetry, CPAP therapy, considered of positive pressure airway pressure if currently untreated, always continue regular PAP therapy. Consider admission to ICU. If you have confirmed but moderate OSA, apnea hypopnea index more than 15 and less than 30 per hour, and he's not receiving regular positive airway pressure therapy, he will treated like the suspected one. If you have a confirmed severe obstructive sleep apnea, confirmed when severe when it's more than the apnea hypopnea index is more than 30 per hour, 30 events per hour, and he's not receiving a regular therapy, PAP therapy, he will go immediately to the intensive monitoring, which is monitored bed setting, continuous saturation monitoring through the pulse oximeter, CPAP therapy, and consider admission to ICU. The last one is confirmed, but he is on regular PAP treatment. The patient is confirmed and he has regular PAP therapy. This patient, high-risk post-operative indicator if he has significant comorbidities like cardiac failure, arrhythmia, obesity, respiratory disease, or high-risk surgical procedure if it's airway, thoracic, intra-abdominal, or extensive or orthopedics, or unable to use CPAP after surgery, or pain sedation mismatch, like we said, it's significant requirement for opioid with or without increased sedation. If this patient have all of this, he will go to the intensive monitoring immediately. If no, so he will have a standard post-operative care with routine surgical ward setting, but always continue and start PAP therapy as soon as possible, and discharge home after minor surgery. Okay, that's all about the anesthesia in this patient. We will go now to answer this question. Are patients with obstructive sleep apnea are at greater risk of severe COVID-19 illness? We said that by definition, OSA patients experience a recurrent nocturnal intermittent hypoxemia, which has been linked to higher incidence of atrial fibrillation and sudden cardiac arrest. Also, OSA can potentially exacerbate inflammation in COVID-19 related sepsis or acute respiratory distress syndrome. Coexisting obesity alert the baseline respiratory mechanics by reducing total lung capacity, functional residual capacity, and the vital capacity, as well as increasing the pleural pressure and upper and lower airway resistance. Obese patients are at high risk developing lung de-recruitment and atelectasis, which are exacerbated by sedatives, supine position, mechanical ventilation. And OSA in the setting of obesity is independent risk factors for severe COVID-19 infection, but some interface can be made from data on ARDS. Obesity has shown as independent risk factor for developing ARDS among hospitalized patients. In a large retrospective study, over 6 million cases, sleep apnea have been associated with an increased risk for development of ARDS among patients undergoing orthopedic and general surgical procedure. The majority of the clinical data don't support increased mortality due to ARDS in obese patients. As well, the patient with obesity hypoventilation syndrome who are hospitalized in general are increased risk for mortality and morbidity. But this risk decreased among patients treated with non-invasive ventilation. How to think about management of airway with patients of OSA suffering COVID-19? We have to think first that we have to decrease the cross-infection. As the patient is important, the medical staff is important too. Airway management for COVID-19 patient can be challenging, as OSA is a predictor of difficult intubation and difficult back valve mask ventilation. Factors such as coexisting obesity can lead to rapid oxyhemoglobin desaturation during rapid sequence induction in an already hypoxemic patient. This can be put healthcare worker in a compromised position as rescue maneuvers such as bag, valve mask, ventilation, supraglottic airway insertion, or cricothyroidectomy are all high-risk aerosol generating procedures. Weaning patients with COVID-19 and coexistent mechanical ventilation may be challenging. OSA patient may be at high risk of failing extubation due to the upper airway obstruction compounded by the rostral fluid shifts and sedatives and underlying hypoxemia. The combination of upper airway collapse with high negative intrathoracic pressure can generate shear forces causing secondary lung injury. Thus, this patient population may be at high risk of prolonged mechanical ventilation. In these cases, tracheostomy may facilitate weaning from mechanical ventilation, and if adapted to apply the non-invasive ventilation through tracheostomy, it can potentially free up the ventilator in resources-limited scenarios. While non-invasive ventilation, such as continuous positive pressure, airway pressure, and bi-level positive airway pressure or high flow nasal oxygenation may be offered as a bridge to extubation under normal circumstances. Weighting the benefit and the risk of viral transmission through the aerosol generation to healthcare workers warrant careful consideration. Alternatively, prophylactic nasal cannula may be applied at extubation in anticipated of hypoxemia with less risk of aerolization, but ultimately does not overcome airway obstruction. This is some ideas used to risk minimization pre-operatively. Given that increased demand and the shortage of resources during the pandemic, it's essential to identify strategies to minimize risk to the patient and health co-workers. Clinicians should prepare for cases when OSA patient will not be able to continue on CPAP or BiPAP and with the clinical benefit versus the risk of transmission. For surgical patient, using regional anesthesia technique whenever possible will avoid high-risk aerosol generating medical procedures, such as airway manipulation and intubation. The literature recommends the following precautions, and I summarized in some points. Use of negative pressure rooms whenever possible with at least 10 air exchange per hour. In absence of negative pressure, patient receiving non-invasive ventilation can be placed in closed neutral pressure room, but with good air cycling. Use of non-ventilated mask. Ensure that the exhalation port is placed in the circuit. A viral filter should be placed between the face mask and exhalation port. The filter should be changed every 24 hours as the moisture from the exhaled gas can increase resistance to the flow. Selection of masks should be considered with priority, from the least aerosol generating to the most. Helmet, full face mask, well-fitting oronasal mask, and least the nasal mask. Sequence of events. Place the mask on before turning on the ventilator and turn the ventilator off before removing the mask. Strict use of PPE when entering the room. Airborne precautions with minimal PPE, N95 respirator, goggles, full face shield, gown, gloves, when non-invasive ventilation is in use. Minimize number of entires of medical personnel. Current guidelines from the Society of Anesthesia and Sleep Medicine recommended continuous use of CPAP through the perioperative period to prevent postoperative complications. Thanks for your attention and your time.
Thank you, Dr. Marianne, for a very perfect lecture. And you covered everything about obstructive sleep apnea patient and the risk factors, either preoperative or intraoperative and postoperative during the ICU unit. And you attack a very important and crucial point about COVID-19 now in the pandemic state, because we suffer a lot from every patient suffering from obstructive sleep apnea and catching COVID virus. We now for a very short time we have today for the end of our scientific day. We need to finish our day, but I would like to express my special thanks for all staff of our department for a lot of effort to prepare the lecture and presented. Thank you very much to Dr. Marianne and Dr. Karim, and first
Thank you, Dr. Eman. Thank you.
Jehan, the head of department, for Dr. Ahmed Fattouh and Dr. Khalid Sarhan, and all my thanks for Dr. Saad for his amazing organization for this scientific day. And I think we can ask Dr. Karim and Dr. Marianne to answer the questions in a written form, because we have no time now. We are too late.
Thank you. 11 p.m.
everybody. Thank you, Dr. Jehan, the head of our department, for your better organization and cooperation and your helpful with our colleague in our department. Thank you very much, everyone.
Thank you, Dr. Eman, and thank you, everybody. Many thanks, Dr. Saad, again and again. I know that we have a great team of maybe senior professors, colleagues in anesthesia department, especially at the unit of the ENT otolaryngology. But with your help and your support, this work came to light, as they say. Thank you very much and good evening.